Bismillahirrahmanirrahim. We are second session of CVS unit. So we were talking about the congenital cardiac anomalies. Firstly, we discussed the ones which were cyanotic, and there was right to left shunt associated with them. Then we started talking about the conditions which are non-cyanotic conditions, that is the left to right shunts, and they are also cyanotic in the later stages. But early on, when the child is born, and even in the early childhood, these stages may remain acyanotic, and the child may remain acyanotic for a very long time. Now we are going to talk about patent ductus arteriosus, which is also one of the known cyanotic congenital anomalies of the heart. So let's begin. Patent ductus arteriosus etiology. The patent due to prostaglandin E2 production by placenta results when ductus arteriosus fails to close after delivery. The ductus arteriosus is a blood vessel. There must be a picture of that. So this is the ductus arteriosus over here. It is a connection between the pulmonary artery and the aorta. In this way, it causes during intrauterine life, it causes the flow of the blood that is flowing in the pulmonary artery to the aorta, because during the intrauterine life, the blood pressure, or you may say the right ventricular pressure, is higher than the left ventricular pressure, and that is how the blood is shunting from the right side, which is oxygenated as well. You must remember that the blood from the umbilical veins that is coming from the placenta is oxygenated, and that blood reaches the right atrium, then left right ventricle, and ultimately into the pulmonary artery, and this needs to be shunted into the aorta because the lungs are collapsed. The lungs are not able to expand, and lungs are not respiring, so the pulmonary resistance is like very high. So because of this very high pulmonary resistance, there is a shunt pathway through which the blood can go into the aorta directly. Coming back, we were talking about the pathology or pathophysiology of the patent ductus arteriosus, or etiology, you may say that. So the prostaglandin E2 is normally produced inside the fetal body to keep the ductus arteriosus patent. If the prostaglandin E2 level does not lower in the body or remains excessively high, so it will cause a patency of the ductus arteriosus, that is called as patent ductus arteriosus. It results when the ductus arteriosus fails to close after delivery. Clinical features: continuous murmur, left to right shunting, wide pulse pressure and bounding pulse, metabolic acidosis, signs of cardiovascular signs, tachycardia, cardiomegaly, Eisenmenger right to left shunting, which will happen later on in life. Wide pulse pressure means the pulse pressure is the difference between the systolic and diastolic pressure. Normally, it is for the adults. Pediatric blood pressure is different. So in adults, 120/80. So this gives us a pulse pressure of 40. If for some reason the systolic pressure is just the same, but the pulse pressure drops down all the way to say 60, or may even you may say that yeah, 60. So now the pulse pressure is equal to 80. That is high. That is higher than the previous one. So why is the pulse pressure increasing in the ductus arteriosus? When the blood is pumped into the aorta, the pressure is very high. So that is like 120-ish. But as soon as the diastole comes, the blood is shunted. The pressure is shunted back from the aorta into the pulmonary artery. So the diastolic pressure, I guess, is lesser in comparison to the systolic pressure. So that is why the pulse pressure is increasing, and there are bounding pulses. I don't know the meaning of that. Let's see that. Bounding pulses. Bounding pulse. Bounding pulse. Okay. So there you go. Because the blood runs out of aorta. The blood runs out of aorta into the pulmonary artery between the heartbeats. The patient's diastolic blood pressure will be somewhat lower than usual. This makes their pulses feel bounding, very strong and forceful. The patients often appear otherwise complete. So basically, we'll try to I will try to make it, understandable. I don't know if I'm very politically correct or not. So suppose that uh, when you are feeling the pulse, that is the systolic beat that you are feeling, right? Now, in the systolic beat, now this is basically the systolic beat which you can feel, and so now by this that if I'm saying that it is a systolic beat, so I mean to say that you feel the pulse whenever the heart is beating, whenever the heart contracts, that which means whenever the ventricular systole occurs. This is the time when you feel the pulse sensation in your hand or wherever you are palpating that. So that is the time when the ventricles are under systole, and when the ventricles dilate or diastole, you don't feel anything, and that is the gap. And after that, you feel the pulse once again. This is the concept of pulse. I'm not going into pressure detail anything else. The pulse is is the pulse or yeah, or the throbbing in your hand on the radial side corresponds to the beating of the heart, right? Now, if the pulse pressure has dropped, so that is sensed by the kidneys. Kidneys will activate the renin angiotensin aldosterone system in uh, angiotensin aldosterone system, and secondly, the sympathetic system will also be activated, which will cause increase in the heart rate. And if the heart rate is increased, the contractility of the heart is increased. Maybe the systolic pressure is increased all the way to 140. Now we know that diastolic pressure is decreased and systolic pressure is increased. So this will further elaborate or enhance the pulse pressure to like it is 40 plus 40, 40 plus 40. Now it is 80. So, it was 60 before. Now it is 80. So it has gone all the way to 80. On top of that, the pulse that you were feeling previously, or if you compare the pulse with a normal patient, so it will be hard. It will be more exaggerated or enhanced. The feeling of that throbbing sensation will be enhanced or exaggerated. This thing is called as a bounding pulse. Moving forward, the treatment, prostaglandin E2 inhibitors, for example, indomethacin or ibuprofen. Ductus arteriosus shunts the blood in utero, left pulmonary artery to the aorta, closes after the birth. Functional closure 18 to 24 hours by the smooth muscles. Anatomic occlusion over next few days to weeks. So functional closure, like it stops functioning in like 18 to 24 hours because the patent ductus arteriosus becomes so narrow that the blood cannot pass through it, or significant amount of blood is not passing through it. And the anatomic occlusion, like fibrosis and all that, that takes few days or maybe weeks. Becomes ligamentum arteriosum. Patency maintained by the prostaglandin E2, major source in utero in placenta. The major source in utero is placenta. The placenta is producing the prostaglandin E2, which will cause the ductus arteriosus to remain patent. Prostaglandin E1 analog maintains the patency of ductus arteriosus. Key effect: delivers the blood to the lungs. Useful when the right ventricle PA blood flow. Okay, useful when poor right ventricular to pulmonary artery blood flow. When that is poor, in those cases we have to maintain this thing. For example, when we have tetralogy of palate or pulmonary atresia, both of them pulmonary atresia, pulmonary valve atresia, maybe pulmonary atresia. Pulmonary atresia. So pulmonary atresia is a birth defect pronounced pulmonary atresia of the heart where the valve that control the blood flow from the heart to the lung does not form at all. That is called atretic pulmonary valve. Okay, so that if I was confusing it with a condition where the lungs are not formed, that is called as pulmonary aplasia. Now we are talking about pulmonary atresia. So in the case of pulmonary atresia, the pulmonary artery, the valve of the pulmonary artery, that is a semi-lunar valve, that is atretic or not formed at all. So in such conditions, both of them will be cyanotic conditions. So in these conditions, if we are supposed to pump the blood into the lungs, so we have to keep the patent ductus arteriosus patent, and we give the L-prostadil for that. And basically for all the cyanotic conditions, we may require to keep the PDA patent until we do the surgical procedure. Endomethacin, NSAID that inhibit the cyclooxygenase, decrease the prostaglandin formation, and can be used to close the PDA. So we can give endomethacin, that is a PGE2 inhibitor, or that inhibits the cyclooxygenase pathway that decrease the prostaglandin formation and can be used to close the PDA. If we look over here, musculoskeletal, okay, just give me a second. Was somewhere over here, yeah, over here. If you look at this picture, so here you can see that the COX pathway from the membrane phospholipid arachidonic acid formed by the COX pathway all the way down, we have the formation of PGE2. We are talking about this one. So the PGE2 production can be inhibited if we give the endomethacin, which is over here. Endomethacin is an NSAID. So the NSAIDs, okay, note this, NSAID will inhibit the production of all the prostaglandins, and in our case PGE2. And if the production of PGE2 is inhibited, so resultantly we are going to get the closure of the patent ductus arteriosus. If the only defect in the child is the patency of the ductus arteriosus, so we can administer NSAIDs, or you may say endomethacin in our case. For example, NSAID, for example, and endomethacin to cause the closure of ductus arteriosus. So I hope that you got the idea. Now moving forward, so the patent ductus arteriosus is associated with a congenital rubella syndrome. Mother, rash. So the rubella causes this condition in the mother, and mother may also be asymptomatic at all. So for example, the mother will have rash, fever, and lymphadenopathy. Baby will have deafness, sensory neural hearing loss, cataracts, and cardiac disease, that is patent ductus arteriosus. There are some 7 other manifestations which can also occur in the patient, in the baby, which are very non-specific, like blueberry muffin rash, or maybe microcephaly, mental retardation, and bone problem, something like that. But the main triad of the rubella is deafness, cataract, and cardiac disease, patent ductus arteriosus. Rare in developed countries due to vaccination, and considered in infants whose mothers are immigrants. Immigrant is a buzzword for non-vaccinated. Uncorrected PDA can cause a differential cyanosis. Uncorrected PDA can cause differential cyanosis, which means occur when the shunt reverses from right to left. Blue toes, normal fingers. Okay, so there will be blue toes because the blood that is, because the ductus arteriosus is present on the left side. So the arteries which are originating on the right side, the upper limb arteries, by which I mean upper limb arteries. So on the right side, brachiocephalic trunk, the subclavian artery and common carotid artery come originating out of that, and the common carotid artery and the subclavian artery on the left side, they will receive enough amount of oxygenated blood. But the blood that was supposed to go to the descending aorta and down to the lower limb, that will be compromised due to the presence of the ductus arteriosus, and resultantly the toes will be blue but the fingers will be normal. So this can be seen in the case of patent ductus arteriosus, but this will be seen later in life, like when the child is like 1 or 2 years old maybe, but not at birth. This condition is not seen at birth. Moving forward, the Eisenmenger syndrome, uncorrected ASD VSD in patent ductus arteriosus, right heart chronically overloaded, right ventricular hypertrophy, pulmonary hypertension. Shunt reverses right more than left bypassing lung. Shunt reverses right more than left. I guess when the pressure on the right side is more than the pressure on the left side and it bypasses the lung. Cyanosis, clubbing, and polycythemia. Very high hematocrit. Okay, so hematocrit will be very high. Polycythemia will be there because whenever there is any kind of hypoxic condition in the body, which will develop if the Eisenmenger syndrome develops due to the shunting of the blood from the right to left side, and the lungs are being bypassed. So resultantly, the erythropoietin secretion will be enhanced by the kidneys, and if erythropoietin secretion by the kidneys is enhanced, so what are we supposed to get? We are going to get cyanosis. We are going to get polycythemia, and hematocrit level will be very high in these children. Moving forward, we have coarctation of aorta. Aortic narrowing near the incision of ductus arteriosus, that is juxtaductal, that is close to ductus arteriosus. Subtype based on the location of ductus arteriosus. Location of ductus arteriosus. So basically, you may say that the subtypes are based on the location of contracture in reference or relative to the ductus arteriosus. So let's see the basic anatomy. It is preductal coarctation. So why is it preductal? Because here we have the coarctation and the ductus arteriosus is located after that. So that is preductal coarctation. And if the ductus arteriosus is present prior to the coarctation, that is called as postductal coarctation, right? Preductal or infantile type. Symptoms varies according to the patency of the ductus arteriosus. Open ductus arteriosus at birth. Ductus arteriosus supplies the lower extremities. Deoxygenated blood to the lower extremities. Lower extremity cyanosis may occur. Ductus cloyer, all flow through the aorta with severe narrowing. Abrupt increased afterload. Rise in left ventricular and diastolic pressure. Acute heart failure. Left ventricle can dilate, fail, and the patient may go into shock. Poor development of collateral vessels, and the key association is the Turner syndrome 45XO. Now, what are they talking about right now? That in this particular condition, when we have preductal coarctation, right? So now let's come to this picture. Suppose that we have coarctation over here. This area is having coarctation. Now, the left ventricle cannot pump the blood into the circulation, specifically the lower limb circulation, because the upper limb may get some blood, or the head and neck may be receiving the blood properly, but the lower limb is not receiving the blood at all, or very little amount of the blood because of the coarctation. But because the ductus arteriosus is patent, so in that case, the blood that is present in the right ventricle will go to the lower extremities. Now, remember one thing, that the blood on the right ventricle is not deoxygenated. That is a misnomer. The oxygen saturation on the left heart, if it is 85%, or maybe it's 96%. I'm sorry. If the oxygenation is 96% on the left heart, so it is 75% on the right heart. It is close to that. Like it is still 75% oxygenated when we call it deoxygenated. So that 75% oxygenation will do good for the lower limbs until and unless we do some surgical operation, right? Because it is better than 0% oxygenation. Along with that, it is nutrients as well. So this blood that is present in the right ventricle is pumped via the ductus arteriosus into the aorta and goes all the way down to the lower extremities and the kidneys and stuff like that. But in case when we have this thing, but in case when we have closure of the ductus arteriosus closure, all the flow of the aorta with severe narrowing, abrupt increase in afterload. Now afterload is very much increased because when this is closed, so due to the closure of that, there is contracture already over here, and on top of that, this thing that was giving the blood, that is also closed now. So the afterload is increased for both the right and left heart. So the total afterload increased dramatically. Secondly, the increase in the afterload was not felt that much before because kidneys were receiving ample amount of blood, but now the kidneys are not receiving any blood or not significant amount of blood because of closure of the rectus arteriosus. Left ventricle can dilate, fail, and may undergo shock as well. And poor development of collateral vessels. Now the collateral development will be seen in the postductal or adult type, but let's keep this in mind that because it is an acute condition, the child is born, the ductus arteriosus closes within 18 to 48 hours, and now the child is in severe kind of acute heart failure and the left ventricle is dilating because it cannot pump any blood, and more blood is shunted into the left ventricle, is coming into the left ventricle from the lungs, and the body is pushing or asking the left ventricle to contract, so the left ventricle may fail and ultimately the body may undergo shock. The poor development of collateral, the collateral circulation will be seen in the next topic. So the key association is Turner syndrome. In the girls who have Turner syndrome, 45XO patient, they have a high chance of developing the preductal or infantile type of coarctation of aorta, and in these patients we have to give them this drug. What was the name of that drug? This one, L-prostadil, to keep the ductus arteriosus patent until we do some surgical maneuver. Then we'll talk about the post-ductal or adult type. Ductus arteriosus does not supply lower extremities. Okay, collaterals develop, may go undetected until adulthood. Lower extremities, low blood pressure, increased drain and release, salt and water retention, that will lead to vasoconstriction, and weak pulses, brachiofemoral delay. Upper extremity and head, high blood pressure and secondary hypertension. Now it is association of coarctation. Okay, let's discuss this one first. Now they're saying that ductus arteriosus does not supply lower extremities. In that condition, when there is post-ductal type of coarctation, so in this particular case, whatever blood is going, the ductus arteriosus may assist in that, but it is not supplying the blood to the lower extremities in the long run, because it is the pressure exerted by the left ventricle that is the main driving force for the blood to reach the lower limbs, right? Now when there is coarctation, so it is sensed as an increase in the afterload by the left ventricle, first thing. Secondly, when the blood supply to the upper limb is ample, but to the lower limb, ample or maybe enhanced, but to the lower limb and the kidneys it is decreased. So what happens is that the lower extremity, low blood pressure, the kidneys will sense a decrease in the blood supply or the blood pressure. They will cause an increase in the renin release, that will lead to salt and water retention, that will cause vasoconstriction and weak pulses. So let's keep it till here. Because of this vasoconstriction, the blood pressure overall in the body should increase, but it increases only in the upper limb because the normal supply of the blood is received by the upper limbs, right? When the upper limb is receiving normal amount of blood, so whenever there is increased salt and water retention and increased vasoconstriction, so resultantly the pressure in the upper limbs and head and neck will be increased, and in the lower limb that will be maintained to the bare minimum level or to the normal levels, right? Then weak pulses, brachiofemoral delay, this is not because of this thing, so that is why I stopped it over here. Weak pulses are a normal finding. Weak pulses or the brachiofemoral delay is a normal finding in the postductal or adult type of coarctation of aorta or postductal type. So what happens over here is that the brachiofemoral delay is there. That is if you feel the pulse of radius along with the inguinal, or you may say the femoral femoral pulse is checked in the inguinal area, so it is called as radiofemoral delay. I'm sorry. So if you check the radial and the femoral pulse simultaneously, you will feel a difference. The radial pulse will be stronger and earlier than the femoral pulse. So that is called as brachiofemoral delay. Upper extremity and head blood pressure upper extremity and head will have a high blood pressure, and secondary hypertension will develop over there. Because of this coarctation, the lower limbs will get low or maybe normal amount of blood, but the upper limbs, they will have increased amount of blood, and the blood pressure in the upper extremity and the head and neck region, that will be they will undergo secondary hypertension. So this is dissociation of blood pressure and dissociation of oxygen delivery in the upper and lower halves of the body, which is seen with the post-ductal or adult type of coarctation. Moving forward, the association of coarctation. First one is bicuspid aortic valve, then we have intracranial aneurysm and Turner syndrome. Bicuspid aortic valve found in about 60% of coarctation cases. The most common associated anomaly with the Turner syndrome. This syndrome can cause bicuspid aortic valve as well as the coarctation of aorta. The early systolic with high frequency click over the apex. Because of the bicuspid aortic valve, you can find early systolic and high frequency click over the apex can be present with aortic regurgitation murmur, okay, associated with a premature calcification or at the 6th decade. Normally the aortic valve calcification occurs at 8th to 9th decade. That can lead to aortic stenosis. Most common cause of congenital aortic stenosis is calcification of the bicuspid aortic valve. NBME point is coarctation with murmur, aortic regurgitation due to bicuspid aortic valve. Okay, so coarctation with murmur is aortic regurgitation due to bicuspid aortic valve. Signs and symptoms of coarctation of aorta. Hypertension in upper extremities, weak, delayed pulse in the lower extremities, that is called as brachiofemoral delay. Murmur over the back between the scapula, the coarctation murmur, okay. The murmur will be heard over the back between the scapula. With age, intercostal arteries enlarge due to the collateral circulation. Arteries erode, notched ribs will be seen. Here you can see that the intercostal arteries enlarge due to the collateral circulation. So what is collateral circulation in the case? I will try to bring a picture of that as well. So suppose that this is the aorta, and here we have the brachiocephalic artery on the right side and the subclavian artery and the common carotid artery. On the left side we have this common carotid artery and this is the subclavian artery, right? And we have coarctation over postductal coarctation is there. So the coarctation is over here, and now we are like talking about a 10 years old child, so there is no significance of the ductus arteriosus because that is one way or the other that is closed. So now the blood is having a tough time to move through the coarctation. So what will the blood do? The subclavian artery has a branch or division that is called as internal thyroid artery. Yeah, internal thoracic artery. So it has a division or a branch that is called as internal thoracic artery. Internal thoracic artery moves in the thorax like this. Suppose this is the thorax, so there we have the internal thoracic artery on each side. The internal thoracic artery is connected to the intercostal arteries. Intercostal arteries are originating from the thoracic aorta, I guess. So there we have thoracic aorta. Normally, thoracic aorta is giving rise to the intercostal arteries which move like this, and they are also connected with the this artery, the internal thoracic artery. So the connection is like this. Like the internal thoracic artery is present on the inner side of the thorax, and that is for the blood supply of the thoracic cavity or the thoracic cage per se, and it is also connected with the intercostal arteries. Now clearing the picture, I will make only one intercostal artery. So suppose this is an intercostal artery, and the direction of blood flow normally is that this is the arch of aorta, and that's a bad picture. Heart is over here. So it is the arch of aorta which is receiving the blood in the descending aorta, and the descending aorta inside the thorax is going to give blood to the intercostal arteries. So the blood flow is like that, and from the subclavian artery the blood is going downward and all the way. Now when the intercostal arteries are not receiving ample amount of blood, why is it not receiving the ample amount of blood? Because the descending aorta is not receiving ample amount of the blood. So from the subclavian artery the blood flows to the subclavian artery, from the subclavian artery down into the internal thoracic artery. From the internal thoracic artery, the retrograde flow of the blood is from the internal thoracic artery to the intercostal arteries, from the intercostal arteries to the aorta. Why is it called retrograde? Because normally the blood flow is from the descending aorta into the intercostals, but now due to this collateral circulation the blood flow is reversed, that is from the intercostal to the descending aorta. And now from the descending aorta, this blood this collateral circulation that is developed cause the flow of the blood into the abdominal aorta, and then to the common iliac arteries, and ultimately to the lower limbs and stuff like that. So this is the collateral circulation that is developed, and due to this development of this collateral circulation, what do we get is that the intercostal arteries, they become enlarged and they erode the ribs, and that is why we see the notching of the ribs. We can see over here. With age, intercostal arteries enlarge due to collateral circulation, arteries erode the ribs, and notched ribs on chest X-ray can be seen. 3 signs: bulge before and after the coarctation on the chest X-ray. What is 3 sign? The bulge before and after the contraction on the chest X-ray. Okay, so here you can see, if I could zoom it in. Okay, so these are the notched ribs. These here you can see the rib is somewhat lifted, and this is also a good example of notching over here. Because why is the notching occurring on the lower border of the ribs? Because the intercostal arteries move on the lower border. And now I guess this is the three sign, like this is the three sign. They will be bulging, and what is that basically? So there is bulge before and after the contraction on the chest X-ray. Bulge before and after the contraction, because listen, this is the aortic shadow. So aorta is contracted or coarctated over there. There is contracture of the aorta over here. So when the heart contracts, there is increased circulation in this area. So this will bulge out, but this area will not move. And then due to the collateral circulation, this area will also bulge out, or maybe during the circulation this is bulging out. So that is called as three sign. That is my interest about that. I've ever heard of the three sign before. So I think that three sign will be this, because they are referring to this one, because these are the bulgings and this is the indentation. So maybe it is three sign, but kindly check this out on the YouTube video for that. Okay, so this is notched rib. Let's check it out over here. Collateral in coarctation. In the coarctation of aorta, the best known collateral vessel in the coarctation of aorta and the occlusion of the subclavian artery are internal thoracic and parascapular arteries that connect the high pressure blah blah blah. Okay, so let's see it over here. The picture is like this, the one with the arrows, I guess this one is a good picture. So here you can see that coarctation of aorta is over here, right? So this is the subclavian artery. This is supposed to be present above it. Like suppose this is the subclavian artery. Subclavian artery gives rise to internal thoracic artery. The internal thoracic artery will receive the blood. It will send the blood directly into the intercostal arteries, the tortuous intercostal artery, which will look like a notching of the rib on the chest X-ray. So this intercostal artery will send the blood back into the descending thoracic aorta. So this is the way the anterior tortuous intercostal artery receives the blood from the anterior intercostal artery. Tortuous intercostal artery receives the blood from the anterior intercostal artery, transfers it to descending aorta beyond coarctation. Tortuous intercostal artery produces notches in the rib. So this tortuosity, firstly it looks like notching, and secondly it may also erode the rib. So that is how it is going to look like notched rib. So this is also a good picture. Okay, so I guess we are good to go with that. So here you can see that this is subclavian artery giving rise to the internal thoracic artery, this one, and this internal thoracic artery is communicating with the intercostal arteries, and intercostal arteries are sending the blood back to the thoracic descending aorta. Now the three sign in coarctation. So the three sign in coarctation is something like this. So this is a good picture, like the same. Yeah, this is a three sign. I was right. So this is three sign over here. This is the three sign. So let's move forward. So the complication of the coarctation of aorta, firstly heart failure. Pressure overload on the left ventricle may ultimately go to the failure. Increased risk of cerebral hemorrhage, very aneurysm, because we saw that it is associated with the intracerebral. It was associated with that. Associated with premature calcification, found most commonly Turner. Just give me a second. Intracranial aneurysm over here occurs in about 10% of patients with coarctation. So that is associated with intracranial aneurysms. Why is there aneurysm? Because the secondary hypertension takes place in the head and neck region. So the blood flow to the head and neck is secondarily elevated because of the renin release from the kidneys and stuff like that. So secondary hypertension causes the high blood pressure in the upper limbs and the head and neck that can lead to the development of berry aneurysm in first place, and the same secondary hypertension can lead to rupture of the berry aneurysm as well. Aortic rupture or dissection, endocarditis and arthritis, high blood pressure across the narrowing, endothelial injury, and low blood pressure distal to the narrowing, bacteria can attach more easily. Okay, so when high blood pressure across the narrowing, whenever there is high blood pressure, so there will be endothelial narrowing, and then after the blood pressure, after the distal to the narrowing, the bacteria may attach more easily because there is stasis of the blood over there. So resultantly there can be endocarditis or end arthritis. Then we have Uworld point, differential clubbing and cyanosis. Without the blood pressure or pulse discrepancy are pathognomonic for a large patent ductus arteriosus complicated by Eisenmenger syndrome, reversal of shunt flow from left to right or right to left. With blood pressure and pulse discrepancy, it is severe pre-ductal coarctation of aorta. So if the question stem is asking you about a child who is like 15 weeks old, not 15, 15 is too much, maybe 6 weeks old. So the difference, he is having clubbing and cyanosis, but there is no difference or discrepancy between the between. Okay, so without blood pressure or pulse discrepancy, so that is patent ductus arteriosus complicated by the Eisenmenger syndrome. Reversal of the shunt flow from left to right and right to left with a blood pressure or pulse discrepancy that is also present, so it is severe preductal coarctation of the aorta. Congenital heart disease associations, a selected inheritance disorder and associated cardiovascular developmental defects. So Down syndrome is associated with an endocardial cushion defects, for example, the ostium primum atrial septal defect, regurgitated atrioventricular valves. The George syndrome is associated with the tetralogy of palate and interrupted aortic arch. Friedreich ataxia is associated with a hypertrophic cardiomyopathy. Cartagena syndrome is associated with a situs inversus. Marfan syndrome is associated with a cystic medial necrosis, for example, the aortic dissection and aneurysm, and mitral valve prolapse. Tuberous sclerosis is associated with a valvular obstruction due to the cardiac rhabdomyomas, and Turner syndrome is associated with the aortic coarctation and bicuspid aortic valve. Okay, so here you can see the disorders. The alcohol exposure in utero. So the alcohol exposure in utero due to fetal alcohol syndrome, it is associated with the VSD, patent ductus arteriosus, ASD, and tetralogy of palate. Okay, so these three are non-cyanotic, while this one is a cyanotic. Congenital heart defect, congenital rubella, patent ductus arteriosus, pulmonary artery stenosis, and septal defect. So pulmonary artery stenosis is a component of the tetralogy of palate, and then it can also have these ASDs and VSD. So basically pretty much the same things. Congenital rubella may cause all of the following things with an emphasis on the patent ductus arteriosus. Down syndrome, AV septal defect, endocardial cushion defect, VSD and ASD, infant of the diabetic mother, transposition of great vessels, Marfan syndrome, mitral valve prolapse, thoracic aortic aneurysm and dissection, and aortic regurgitation, prenatal lithium exposure, Epstein anomaly, Turner syndrome, bicuspid aortic valve coarctation of aorta, Williams syndrome, supravalvular aortic stenosis, and 22q11 syndrome, truncus arteriosus, and tetralogy of palate. Now, if we have CVS system, fetal erythropoiesis, how is that taking place? The fetal erythropoiesis occurs in 1, 2, 3, 4, 5. Okay, so this is the graph which we are supposed to study, but we'll come to it later. First, let's study it from here. So, yolk sac in first 3 to 8 weeks, liver 6 weeks till birth, spleen 10 to 28 weeks, and bone marrow 18 weeks to adult. Young liver synthesizes blood. So, firstly in the yolk sac, then in the liver, then in the spleen, and ultimately in the blood. Okay. So, it is not like liver and spleen have alternative production of the blood. It starts in the liver and then also starts in the spleen until birth. Okay, so here you can see that in first 4 weeks, like before 6 weeks, it was happening in the yolk sac. After that, it started in the liver till birth, in the spleen from 6 weeks, from 10th week to 28th week, from 10th to 28th week. Okay, I'm sorry, to 28th week. Okay, I'm sorry for this line, but 10th to 28th week it is happening inside the spleen and in the liver till birth, and in the bone marrow it starts happening from the 18th week to adulthood. From the 18th week to adulthood, here you can see that the production in the liver, spleen, and bone marrow is kind of overlapping. So it starts happening in the bone marrow on the 18th week and till adulthood, and even till death it starts happening in the bone marrow. It keeps on happening in the bone marrow. So this is the basic mechanism or basic framework of the erythropoiesis. So hemoglobin development, embryonic globin, zeta and epsilon chains. So embryonic globins are zeta and the epsilon chains. The fetal hemoglobin, HbF alpha 2 gamma 2. The adult hemoglobin is HbA alpha 2 beta 2. So here you can see that in the embryonic stages. So this is some very weird kind of terminology, that when is embryo called a fetus. Let me see that and remember that for good, because that is kind of weird. Embryo versus fetus versus neonate versus infant. So when an egg and sperm meet, a zygote is formed and quickly begins dividing to become an embryo. So the morula stage and the blastocyst, all of that thing is called as an embryo. As the pregnancy progresses to embryo, as the pregnancy progresses, the embryo becomes fetus, okay, and the fetus becomes a neonate or newborn at birth. So this is something. So the embryo is the structure. Embryo is basically a group of cells. It is called embryo. So when is it called embryo? So just don't go to that details that on flam week it is called as fetus and flam week it is called as blah blah. Just stop it. So very early on till the 4th week, it is, yeah, here you can see it is till 6th to 7th week also. It is having it is called as an embryo, and these are having zeta and epsilon chains. So these are very weird kind of different chains. These are the two structures which are forming the hemoglobin in utero in the embryonic stages. When the erythropoiesis begins, like in the 4th week or 3 to 8 weeks, it is the hemoglobin that is present in the red blood cell, that is zeta and epsilon chains. The fetal hemoglobin, that is when the baby is a bit mature but is still in the uterus and during the intrauterine life. The baby or fetal hemoglobin is alpha 2 gamma 2 predominantly. The adult hemoglobin is alpha 2 beta 2. Okay, the SBF has higher affinity for oxygen due to less avid binding of the 2,3-bis phosphoglycerate, allowing the SBF to extract the oxygen from the maternal hemoglobin, HbA1 and A2 across the placenta. Why is it having the higher affinity? Because the maternal circulation, the mother has HbA1, so it needs to have higher affinity than HbA1 to extract the oxygen from that. So the mechanism of high oxygen affinity is that it binds less heavily to the 2,3-bis phosphoglycerate. Moving forward to the fetal circulation, now let's talk about that. So fetal circulation, the blood in the umbilical vein has PO2 of about 30 millimeters of mercury and is 80% saturated with oxygen. Umbilical arteries have low oxygen saturation. Okay, so the umbilical veins have 30 millimeters of mercury oxygen pressure. Normally for the adults, the pulmonary arteries are having 104 millimeters of mercury oxygen, but then the demand for the adult body is different than the fetus, because fetus is not doing basically anything on its own. Yeah. So the umbilical vein contains 30 millimeters of mercury. So where is the umbilical vein? This is placenta, and these red structures associated with that are umbilical veins, because they are the ones having oxygenated blood during intrauterine life. The arteries are purple because, or blue you may say that, because they are carrying the deoxygenated blood back to the maternal circulation. So the umbilical veins are having oxygenated blood, and the oxygenation is 80% saturated and 30 millimeters of mercury. 3 important shunts. Blood entering the fetus through the umbilical vein is conducted via the ductus venosus into the inferior vena cava, bypassing the hepatic circulation. So here you can see that umbilical veins are going into the portal venous system, I guess that is given by the Wittline venous system. So let me check. It was in the very beginning of the chapter. Maybe over here. The venous system. Okay. Yeah, here you can see the Wittline veins were giving the portal veins, the cardinal veins were giving the systemic circulation of superior vena cava, and the umbilical veins were going to degenerate. So here you can see that the first connection, the first shunt to be formed between the umbilical artery, so that takes the oxygenated blood from the umbilical artery directly into the inferior vena cava. This is inferior vena cava. This is umbilical artery. Let me use a different color. Okay, this is good color. So this is umbilical artery. This one umbilical artery. This one is inferior vena cava. So the vein that is connecting these two structures, that is called as ductus venosus, that is present over here. This is ductus venosus, and this is connecting the umbilical vein directly with the inferior vena cava, bypassing the hepatic circulation that is maintained by the initially by the Wittline veins, and then they become the portal veins and stuff like that. So this is ductus venosus over here. This is the first shunt. Second shunt is most of the highly oxygenated blood reaching the heart via inferior vena cava is directed through the foramen ovale and pumped into the aorta to supply the head and the body. So now here we have a patent foramen ovale. Intrauterine life it is normal. So that blood is shunted into the left atrium via foramen ovale, then into the left ventricle, and then into the aorta, all the way to the upper limb and the head and neck. Deoxygenated blood from the superior vena cava passes through the right atrium and the right ventricle, the main pulmonary artery, patent ductus arteriosus, descending aorta. Shunt is due to high fetal pulmonary artery resistance due to the partly to low oxygenation. Pardon me. Deoxygenated blood from the superior vena cava. So the blood from the superior vena cava is deoxygenated, and from the inferior vena cava it is oxygenated. Remember this thing; it is very, very important that the blood that is present in the inferior vena cava is coming from the umbilical veins, and the umbilical veins are carrying oxygenated blood, right? But the superior vena cava, the blood in the superior vena cava is coming from the head and neck, and it comes after being supplied by the aorta, and the deoxygenated blood from the head and neck is coming back through the superior vena cava. That is why the superior vena cava is having deoxygenated blood. Now this deoxygenated blood will go to the right atrium, from there into the right ventricle, and then from the pulmonary artery, from the ductus arteriosus into the descending aorta, and from the descending aorta it will go all the way into the umbilical arteries to be to enter the placenta and ultimately into the maternal circulation to get oxygenated. So remember these things. At birth, deoxygenated blood from the superior vena cava passes through the right atrium, right ventricle, main pulmonary artery, patent ductus arteriosus, descending aorta. Shunt is due to high fetal pulmonary arterial resistance due to the partly to low oxygen tension. Yeah, because the lungs are like, you know, this thing. They're pretty much collapsed. So the blood cannot move in that direction. That is why it is shunted to the aorta via ductus arteriosus. At birth, the infant takes a breath that decreases the resistance in the pulmonary vasculature, increases the left atrial pressure versus the right pressure. So let's keep it here. They are saying that when the infant is taking breath, so let me remove these things. When the infant is taking breath, so there is decreased resistance in the pulmonary vasculature. Why so? Because lungs have expanded all the way to this much level, and when the lungs are expanding, the arteries and the arterioles and the capillaries which were previously collapsed inside the lungs, they are open now. So the afterload for the right ventricle is decreased. That is why the blood starts moving into the lungs, except instead of going into the ductus arteriosus. Secondly, the left atrial pressure is increased. Why is the left atrial pressure increased? Because if the blood is entering the lungs, it will also leave the lungs, and if it leaves the lungs, it will enter the left atrium by the pulmonary veins, and the left atrium will drain into the left ventricle. So that is how the left atrial system, the left heart, has now increased amount of pressure or increased pressure in comparison to the right heart. Okay, got it. Then foramen veil closes, now called as fossa ovalis. The foramen veil, why is it closing? Because when the left heart is having more pressure than the right heart, so the valve, the septum primum, I guess, is acting as a valve. Yeah, so septum primum will fuse with the septum secundum to close the atrial septum, and the foramen veil will become fossa ovalis. Increased oxygen from the respiration and decreased prostaglandin from the placental separation. Closure of ductus arteriosus. In utero, the PGE2 was being provided by the placenta mainly. Now the placenta is gone, so the PGE2 production is decreased. Secondly, due to increased concentration of oxygen, we know that for the systemic circulation, increased amount of oxygen is going to cause vasoconstriction. Increased oxygen amount in the systemic circulation causes vasoconstriction. So that is why the ductus arteriosus will be closed. Now there is a side note which has nothing to do with this, but it is a connection type from the respiratory system, that the increased concentration of oxygen in the pulmonary circulation causes vasodilation, and hypoxia causes vasoconstriction in the pulmonary circulation. Okay, remember these things. Now these two things, that is increased oxygen from the separation which causes vasoconstriction in the systemic circulation, and decreased prostaglandins from the placental separation, leads to closure of the ductus arteriosus. Indomethacin helps to close the patent ductus arteriosus. Ligamentum arteriosum is formed in response to the closure of ductus arteriosus, and remnant, okay, that is the remnant of ductus arteriosus. Prostaglandin E1 and E2 keep the PDA open. Okay, so there is a Uworld point. The Uworld point is the highest value of oxygen saturation is recorded in the inferior vena cava in fetal circulation, as it carries the oxygenated blood from the umbilical vein. In utero, the pulmonary vascular resistance is very high. The right atrial pressure is high in comparison to the left atrium, which has the lower pressure. At birth, the pulmonary vascular resistance decreases, the right atrial pressure decreases, and the left atrial pressure increases. That is why the foramen veil closes and it becomes fossa ovalis. Okay, this is an important Uworld point. That is, the highest value of oxygen saturation is recorded in the inferior vena cava in fetal circulation. Fetal postnatal derivatives. Allantois will give rise to urachus, right? And that urachus becomes median umbilical ligament. The urachus is basically the connection between the umbilicus, the belly button, to the urinary bladder. So that is urachus, and that, if closes, becomes the median umbilical ligament. Urachus is the part of allantoic duct between the bladder and umbilicus. The ductus arteriosus will become ligamentum arteriosum. This is the PDA thing, patent ductus arteriosus. So this will become ligamentum arteriosum, and that will be seen between the pulmonary arteries and the aorta, which looks like this. Pulmonary artery is situated anteriorly, and pulmonary artery and the aorta is posterior to that. So this is the position where we find the ligamentum arteriosum. Let's remove this. Then we have ductus venosus. That will become ligamentum venosum. Remember what is ductus venosus? The ductus venosus is the first shunt that is connecting the umbilical arteries to the inferior vena cava, and that will become ductus venosum. That ductus venosum will become ligamentum venosum. After that, we have foramen ovale, that will become fossa ovalis. Notochord, that is nucleus pulposus, that is in the CNS, that will become nucleus pulposus. Umbilical arteries, they will become medial umbilical ligament. So you have to differentiate between these two. So because these are umbilical and they have no N in that, so they will become medial umbilical ligament, while the allantois derived uricus will become median umbilical ligament. Umbilical vein, it will become ligamentum teres hepatis, okay, ligamentum teres of the liver, and confined in the falciform ligament. Got it. That is umbilical vein. So remember these things, they're very, very high yield. They're important because these are the things and these are the things. Basically, they ask you about pretty much everything. Ligamentum teres. So what is ligamentum teres hepatis? A remnant of the umbilical vein. Okay, so fissure of the ligamentum teres hepatis is over here on the liver. Lies within the free edge of the darker falciform ligament and attaches the liver to both the diaphragm and the anterior abdominal wall. Falciform ligament is basically connecting the liver to the anterior abdominal wall and the diaphragm. So this is a component of that. Ligamentum teres hepatis is a component of falciform ligament, and this is the remnant of umbilical vein. Okay, it divides the anatomic left and right lobes. So this divides the anatomic left and right lobes of the liver, and easily seen as darker structure on CT scan. It contains some fat. So this is basically the fissure of ligamentum teres. Ligamentum lateral segment left lobe, middle segment is the, okay, so these are the lateral segment of the left lobe and middle segment of the left lobe, and fissure of ligamentum venosum. The anatomic left and right lobes of the liver are given by this one. So let me see the ligamentum teres hepatis. Ligamentum teres of the liver. The ligamentum teres of the liver is present over here. So this is basically the falciform ligament present on this thing is called the falciform ligament, this one, and I guess this is the ligamentum teres hepatis. Ligamentum teres hepatis. I hope it is ligamentum teres. Yep, this is the ligament. No, this is round ligament. Yeah, round ligament of the liver is also called the ligamentum teres hepatis. So this contains, or this is the remnant of the umbilical veins. Now let's come back. Here we have anatomy of the CVS. What we were doing till now was the embryology of CVS. Now we are going to do the anatomy of CVS. Anterior posterior structures. Right ventricle is the most anterior structure. The left atrium is the most posterior structure. Okay, so right ventricle, then we have left ventricle, left lateral structure, and right atrium is the right border of the heart. Okay, so remember these two because they're very, very high yield. The right ventricle or the anterior structure injured if penetrating trauma at the mid and lower left sternal border. If at the mid and lower left sternal border any stab wound is happening or anything is entering your chest cavity, so that is supposed to damage the right ventricle because that is the most anterior structure. The parietal pleura would be injured as well, but the left lung itself would not be punctured as there is no middle lobe on the left side, and the superior lobe of the left lung is displaced laterally by the cardiac impression. Okay, so if anybody has calculated the distance from the sternum to the apex, and now that is stabbing you in the I guess second to fifth intercostal space on the sternal border specifically, so he may damage your pleura and heart, but he will save your lungs. Okay, left atrium posterior enlargement can cause dysphagia because the most posterior structure, or the structure that is adherent to the esophagus, that is situated behind the heart, is the left atrium. Enlargement can cause dysphagia due to the compression of the esophagus, or hoarseness due to the compression of left recurrent laryngeal nerve, a branch of the vagus nerve, the closest to the probe of transesophageal echo. So when we do the transesophageal echocardiography, so this is suppose this is esophagus. I'm making a lateral picture. So we give a esophagus transesophageal echocardiography, and we keep the probe anteriorly. So this is the left atrium that is facing the probe. This one is left atrium, and then is the left ventricle. Okay, so stuff like that. Then the left atrial appendage is particularly susceptible to thrombus formation. This left atrial appendage, the appendage is like this portion. If suppose this is the left atrium, and then we have the left ventricle associated with that. So this thing over here is called as the left atrial appendage, and that is most susceptible to the thrombus formation because there is highest amount of turbulence. There is high amount of turbulence in this appendage. Then the left ventricle is the left lateral aspect of the heart. Suppose this is the heart I'm drawing. This is the left side of the heart. This is the right side of the heart. So the left lateral border is formed by the left ventricle, and the right border of the heart is formed by the right ventricle. Right atrium, I'm sorry, because right ventricle was forming the anterior structure. So the left lateral aspect of the heart, a stab wound angled slightly medially in the fourth intercostal space at the mid-clavicular line could strike the left ventricle, but only after passing through the bulk of the left lung. Okay, so it has passed. So the your murderer has to take good care of the placement of the knife. Otherwise, so he has to take a good care of angle. If the wound is angled slightly medially in the fourth intercostal space at the mid clavicular line, and we are talking the left side, so because right side does not contain the heart, so on the left side he has to angle this very appropriately. On top of that, the line could strike the left ventricle, so he could strike the left ventricle, okay, without missing it, but only after passing through the bulk of the lung tissue. So he has to damage the parietal pleura, then the visceral pleura, then the lung tissue, and then he has a chance of getting to your heart. Right atrium. Right atrium is making the right border of the heart. A penetrating injury at the sternal border in the fourth intercostal space left of the nipple will pass through the four following layers. Okay, so if there is penetrating injury at the left sternal border in the fourth intercostal space, level of the nipple will pass through the following. So that is very interesting. That is not related to this one definitely, but it is interesting in a sense that the fourth intercostal space contains the nipples, and it is also the T4 dermatomal level as well. Okay, come back. So what are the layers that your murderer has to penetrate? Firstly, skin and subcutis, then pectoralis major muscle, then external intercostal muscle, internal intercostal muscle, internal thoracic artery and veins, transversus thoracic muscle, because these structure, neurovascular structure of your thoracic cage, move between the internal and transversus thoracic muscle. Okay, then the parietal pleura, after that pericardium and the right ventricular myocardium. So all of these layers have to be pierced. 9 layers have to be pierced to reach your heart. Okay. Oh, you may say 8 layers because after that you have the right ventricular myocardium. Okay. Correct. Then you have transesophageal echocardiography. I was talking about this one. So here you can see that this is the probe all the way placed anteriorly into the esophagus, and it is facing the left atrium. So this is transesophageal probe, transesophageal echocardiography probe, and it is facing your left atrium. Here you can see that the cardiac notches of the lung. So bare area of the pericardial sac. The bare area of the pericardial sac is over here. Left sternal margin at the fifth intercostal space gives direct access to the pericardial sac. Cardiac notch in the left lung provides access to the heart with a needle. Okay, I guess this is for the biopsy or stuff like that. So we'll see these pictures. These are the CT scan images. They are very important because sometimes they ask you about these CT scan images. We'll discuss that in the next session. Until then, Allah Hafiz, fi amanillah, and take care.